Vanakkam. When we come across a patient with a median nerve palsy in our consultation, there are a few steps to be followed. It is quite simple managing these cases in the consultation clinic, provided we do a thorough clinical examination and then work up the patient with the necessary investigations, interpret those investigations, and then comes the important process of making a decision. What to do for this patient so that he can get back good function. We'll go through all those steps in this video and show the thought process in the decision making for a patient with a median nerve palsy. We shall go through this discussion about a patient presenting with median nerve palsy following the usual steps of presentation, clinical findings that were noted, the investigation reports that were seen, the diagnosis, planning the management, and after making a plan, discussing with the patient and the caregiver. All these steps need to be done in the consultation clinic before the patient is subjected to any surgical procedure. A 45-year-old manual laborer presented with a history of injury sustained 1 year ago by a flying splinter from a machine which struck his left forearm. He had noticed a blunting of sensation on the palm immediately after the injury, but only a skin suturing was done at a local hospital and there was no referral or splints or therapy advised. He continued to use the hand, but he has now come for consultation because he has noticed continued loss of sensation and weakness of thumb movements. I shall discuss the clinical findings under the headings of inspection, palpation, motor testing, sensory testing, and other findings like the vascularity and examination of the other nerves in the hand like the ulnar nerve and the radial nerve. Before we go in to see the clinical findings in this patient, I would like to make a clarification. Since the details of this patient have been taken from my patient database and archives, some of the video recordings of the findings were not available. Hence, for completion's sake, I have added the findings and the methods of testing the muscles in other individuals. This is for sake of completion of demonstrating the clinical methods of examination of a case of median nerve injury. Here you will note that the thumb is in a position of adduction and at the level of the palm. This is typical of a patient with a median nerve injury alone. If it had been a combined ulnar nerve injury, there would have been radial abduction of the thumb brought about by the active radial nerve muscles like the abductor pollicis longus. In this patient's hand, we can note wasting of the thenar eminence that is obvious over the radial half of the palm. A trophic ulcer was noted over the radial aspect of the terminal phalangeal region and middle phalangeal region of the middle finger with areas of healing and desquamation. This area on the middle finger represents the contact area and is prone for trophic ulcer development. Autonomic changes are seen in the skin with a dry scaly appearance. A 2 cm transverse scar is noted over the middle of the forearm on the flexor aspect. During inspection, the patient is asked to oppose his thumb to the fingers to the maximum and it can be graded according to the Kappanji grading system. This grading is from a score of 1 to 10. When the patient is able to touch radial side of the proximal phalangeal region of the index finger only, it is known as grade 1. The grading progressively increases as he is then able to touch the radial side of the middle phalanx of the index finger, then the tips of the index, middle, ring and little fingers, then progressively down, that is the distal interphalangeal joint crease of the little finger, the proximal interphalangeal joint crease, the metacarpophalangeal joint crease of the little finger, and then lastly the distal palmar crease. Palpation of the forearm and scar in this patient revealed that there was no adherence of the scar and there was no appreciable swelling either proximal or distal to the scar. And thirdly, there was a static tinel sign at the level of the scar alone. When formally testing the motors, we need to do two tests. the pen test and the muscle tests. The pen test is done to test the palmar abduction movement of the thumb. This is first demonstrated on the normal hand, and the patient is asked to touch a pen which is held parallel to the level of the palm, and the patient is asked to lift his thumb up to touch the pen. This is then tested on the affected side, and while the patient is doing this, we need to palpate for the contraction of the underlying muscles to confirm that it is the abductor pollicis brevis that is acting. In this patient, as demonstrated, the pen test was negative. Then the individual muscles were tested, and in case of each muscle that was tested, 4 points were noted. Was there movement caused by the contraction of the muscle? And we confirmed by palpating the muscle or the tone of the muscle that was contracting, and we confirmed that no other muscle was acting. That is, there is no trick movement involved in carrying out that action. And lastly, the power of the muscle according to the MRC grading was also recorded. All the muscles innervated by the median nerve were tested in this order. To test the pronator teres muscle with the patient sitting and elbow in flexion, he is asked to pronate the forearm, and at the same time the muscle is palpated and the power is also checked. To test the flexor carpi radialis, the patient is asked to flex the closed hand at the wrist. At the same time, we need to note a few points. 1. Is there an ulnar deviation of the flexing wrist which could be caused by the flexor carpi ulnaris? Second is, we may sometimes be able to see or just palpate the taut tendon of the flexor carpi radialis. The power of the muscle should also be checked. We shall now check the method of testing the flexor digitorum superficialis of the fingers. We shall start with the middle finger. The flexor digitorum superficialis acts on the proximal interphalangeal joint to flex it, but there is another tendon, that is the flexor digitorum profundus, which can also act on the proximal interphalangeal joint to flex it. To prevent this flexor digitorum profundus from acting, we ask the patient to keep the palm of the hand facing upwards flat on the table, restrict the index, ring and little fingers, and then ask the patient to flex the middle finger. This is because the flexor digitorum profundus belly of the middle, ring and little fingers is common. So when the ring and little fingers are restricted, the flexor digitorum profundus to the middle finger cannot act, and whatever flexion we get at the middle finger proximal interphalangeal joint is due to the flexor digitorum superficialis alone. This, however, must also be tested. Once the patient flexes the middle finger completely, he is asked to maintain the flexion, and the tone of the distal interphalangeal joint must be checked. It must be relaxed and loose. If it is tight, that means there is some trick movement and the patient is still using the flexor digitorum profundus to flex the interphalangeal joint of the middle finger, because the FDS is not acting. In a similar fashion, by restricting the middle and little fingers, the ring finger FDS can be tested, and by restricting the middle and ring fingers, the little finger FDS can be tested. But the FDS of the index finger cannot be tested in this fashion, because the FDP of the index finger is a separate muscle. Here, the patient is asked to flex the proximal interphalangeal joint, and the tone of the distal interphalangeal joint is checked to make sure that the FDP is not performing the flexion of the PIP joint. The palmaris longus can be tested by asking the patient to attempt to oppose the thumb and little fingers and then flex the wrist against resistance. The palmaris longus again may be palpable when it is contracting. The flexor digitorum profundus of the index and middle fingers can be tested by stabilizing the middle phalangeal region of the fingers and asking the patient to actively flex the distal interphalangeal joint. The flexor pollicis longus muscle can be tested by supporting the proximal phalangeal region of the thumb and asking the patient to actively flex the interphalangeal joint. To test the pronator quadratus, it is not enough to ask the patient to pronate the forearm. This is because the pronator teres will most probably act. To negate the action of the pronator teres, we put the patient in supine position, acutely flex the elbow, and then ask the patient to pronate the forearm. This can be done while the examiner resists the movement. To test the first and second lumbrical muscles which are innervated by the median nerve, the patient is asked to keep the index and mid finger straight and flex only the metacarpophalangeal joints. Resistance is applied to test the power of the lumbricals. So when testing the opposition movement in a patient, we need to compare with the opposite side and at the same time palpate the abductor pollicis brevis, which is the first palpable muscle radial to the first metacarpal bone. There are trick movements that can occur, like in this patient in whom opposition seems to be present but there is a loss of tone of the abductor pollicis brevis, which means that the median nerve is involved. In this patient, after completion of all the muscle testing, it was noted that the deficit was only at the level of the hand, that is, the lumbricals 1 and 2, the opponent's pollicis, the abductor pollicis brevis, and the flexor pollicis brevis were involved. Hence, the level of injury was the trunk of the median nerve distal to the anterior interosseous nerve branching. Sensory testing revealed loss of sensation on the thumb, index, middle and the radial side of the ring finger. The clinical examination was completed by conducting the other tests and confirming the good vascular status of the hand, by confirming that the ulnar nerve and the radial nerve were totally intact and the function of the probable donor muscles, that is, the extensor indicis proprius and the extensor carpi ulnaris were also confirmed. X-ray revealed no foreign body as can be expected when there is an injury by a flying splinter. Ultrasound showed a gap in the continuity of the median nerve at the level of the mid forearm. MRI showed the proximal and distal swellings of the neuroma and glioma, and a nerve conduction study showed total sensory motor conduction loss of the median nerve on the left upper limb. The complete diagnosis in this patient would be post-traumatic sequelae, injury to the median nerve at the level of the mid forearm of 1 year duration involving the non-dominant left hand in a 45-year-old manual laborer. Having come to a clear diagnosis, we need to plan the management. As always, it is easy to plan the management when you have 3 columns. One is the problem that should be solved. Second is the solution to the problem or the aim in solving that problem. And finally, the procedure that has been planned to fulfill that aim. The first problem is that he has had an injury to the nerve in the forearm. Now the aim here would be to see the status of the nerve and the tissues to be able to take a final decision of management. The planned procedure for this should be an exploration. The second problem is there is no sensation on the radial 3.5 fingers of the left hand. So we need to restore sensation in the hand, especially the radial fingers which are important for the grip. This can be achieved by a procedure known as the nerve reconstruction. The third problem is that there is no opposition movement. So we need to restore the lost movements in the hand. This can be achieved by a tendon transfer since it is a 1-year-old injury. We generally know that by about 9 months, the motor end plates of the muscles have usually degenerated, and even if the nerve is able to grow into these motor end plates, the activity of the muscle cannot be recovered. We have broadly planned for 3 procedures: exploration, nerve reconstruction and tendon transfer. We shall now see the details of each of these procedures. The aims of doing an exploratory procedure would be to assess the status of the injured nerve, to free the nerve from the surrounding scar, and to finalize the provisional plan that has been made already. The nerve reconstruction that we have planned is primarily to get back sensation on the radial 3.5 fingers of the hand. This can be done either as a primary repair of the cut ends of the nerve or a reconstruction. This can be decided only after excision of the proximal neuroma and the distal glioma. Usually there will be a gap between the two ends after this procedure. If the gap is more than 2.5 centimeters or primary tensionless suturing between the two ends of the nerve is not possible, we will need to do a reversed sural nerve graft, and we may need about 3 cables of the sural nerve to accommodate the size of the median nerve at this level in the forearm. The available options for tendon transfer are using the flexor digitorum superficialis of the ring finger, using the abductor digiti minimi, using the palmaris longus or extensor carpi ulnaris or the extensor indicis proprius. The FDS of the ring finger, if it is used, may result in reduced grip strength, and this may not be ideal for this manual laborer. The abductor digitae minimi is usually used for opponentsplasty in congenital hypoplasia of thumb. The palmaris longus is a very weak transfer and it is only a positioning transfer. The extensor carpi ulnaris can also be used, but we do not want to weaken the extension in this patient. Hence, the extensor indicis proprius transfer can be done, that is the Burkhalter's opponentsplasty. So in this procedure, we are planning to use the extensor indicis proprius as a motor for getting back opposition of the thumb. We will be using the pisiform pulley for rooting the tendon and inserting it into the abductor pollicis brevis insertion, followed by immobilization for 3 weeks and then the required therapy. So the plan is exploration, nerve reconstruction with reversed sural nerve graft and EIP opponentsplasty. But when making a plan in hand surgery, it is not just deciding what procedures are to be done, we also need to decide and plan on the timing. Are these procedures going to be done together or are they going to be done in different stages? Considering this patient, all the 3 procedures required need immobilization after surgery, and the basic requisites of all 3 procedures have been met. Like for instance, the joints are soft and supple and there is no problem with the skin, and the time duration for conducting all the 3 procedures is well under control, a total of around 3 hours. So now the final plan has been made of a single stage procedure with exploration, nerve reconstruction with reversed sural nerve graft and extensor indicis proprius opponentsplasty. After making the final plan, it is very important to communicate with the patient and the caregiver about many of the aspects of the surgery and the aftermath. The first thing we need to communicate is the details of the planned surgery, not only the procedure but also the duration of the procedure. We should talk to them about the scar that is going to develop on the hand and forearm, and also on the leg if a sural nerve graft is going to be taken, the resulting loss of sensation on the lateral aspect of the foot when a sural nerve graft is harvested, the weakness of extension of the index finger after the tendon transfer, that is the harvest of the extensor indicis proprius. We also need to explain to them that it may be temporary and it will usually recover, and finally the duration of about 2 to 3 hours of surgery, so that the patient's attenders who are waiting outside will not get anxious when there is a delay. The next point we need to talk about and discuss with the patient is that the procedure would be done either under regional block or under general anesthesia, and ask the patient's preference also, as it would help in the comfort of the patient. The period of expected hospitalization and the expenses that may incur should also be discussed. Usually the period of hospitalization would be a couple of days. The need for hand elevation should be explained to the patient, and the expenses should be explained according to the situation and the institution. And the importance of review as an outpatient after being discharged from the hospital should also be informed to the patient. At the same time, the need for immobilization of the hand in a plaster of Paris slab should also be informed to the patient. And not only that, after the immobilization period is over, when the POP is removed, the need for therapy should also be stressed in the preoperative counseling itself. The need for scar massage, active and passive mobilization as needed, and sometimes the need for electrical stimulation of the thenar muscles should also be informed to the patient at this juncture. All patients and caregivers will always be anxious about the expected results. We need to explain to them about what can be expected in our hands. We can show previous results if available, and this can be in the format of either pictures or videos of our own patients. And we also need to stress that our aim is to allow opposition of the thumb to the index and mid fingers, and also get back some protective sensation so that work can be carried on with the hand. We should also talk to them about the complications that can occur, like delayed skin healing, a resulting weak opposition after the surgery that may require a corrective surgery. And finally, whatever we have spoken to the patient should be recorded, if possible in handwritten format, and signed by the patient, the attender of the patient, by the staff nurse in charge of the patient, and by the treating surgeon. This will make for a good consent form. I hope you liked the video. I enjoyed making it. Do click on the shown links to see more about median nerve anatomy and the clinical features of the median nerve. And do not forget to subscribe to stay connected with the latest in learning hand surgery. Vanakkam.